Hello, everyone, and welcome to the Healthcare Inspired Podcast, Season 3, The Connected Leader. We are back with another episode, and I want to welcome to the stage my good friend and co-host, Maya Turner. Hi, Maya.
Hello. Hi. Good to be back again.
So excited. I'm so excited.
Yes.
Now, I know we've had a lot going on over the last few weeks. We talked about all of our adventures, and I know you just got
Yes.
back from California. I got back from
Yes.
Knoxville. How
Yes.
was your May Mania in person in Orange County?
It was so much fun. Lady Martinez is an amazing soul. I went axe throwing for the first time. I got invited to their company event and we went axe throwing. And I'm ashamed to say I was good at it.
Oh, watch out.
No, I did okay. My husband was really good at it though, but we had a great time. It was good to have a tangible meeting. I think we're getting away from that, right? We talked about that last week, and it was such a good time. We talked about Modifier 25. I gave some examples. I met everybody in person. It was just so nice. And California is the dreamiest place. Oh my gosh. I stayed at the Atrium and it was the pool. Yes. I
No, I'm
loved.
not going to argue with you. It's my home. So
Yes,
I'm from
that's
there. So yeah.
it was an amazing, it was really, really good. It was something that was really needed. And it's so different than going to a conference because conferences are like every day. But, we only had one day for speaking and then I really got a chance to enjoy myself. So it wasn't so busy. So I had the best time. Really, I did. Thank you, lady.
I'm so happy. I had a great time too. It was really exciting. And, James Mitchell, who is who's heading up the chapter there in Knoxville, like he just did this whole thing about me. And they had me speak for 2 sessions. And so I was
Oh,
honored that I got to speak on G2211, and then also I spoke on chronic care management, principal care management, and transitional care management, the
oh
acronyms,
boy.
right?
Yeah.
And I
Yeah.
don't do primary care as a rule. And so I told them that the focus of my presentation will be focused on helping, because I work with specialists, surgeons, and
Right.
those
But
kind of
it's still
offices. And
important.
so
Transitional
it
TCM is
is.
still important for specialties. Yes.
Yeah, so you have to know the difference between them, especially so you don't try to do it and know you're not supposed to. So,
Yeah.
like,
Yeah.
that's where the presentation was kind of focused. So,
Right. Overlapping.
recently, we had, I don't know if you listen to, the compliance guy, Sean Weiss, and they have their
Of
coding
course.
roundtable, right? Yeah, every week.
Yes.
So recently they talked about staying in your lane. And then recently Terry Fletcher talked about, on her latest episode, is gold, by the way. You need to go listen to it if you haven't yet. It's about consultants
Yeah.
really claiming that they know it, but they don't.
And
And
they really don't trying to fake it till you make it. Mm-mm.
not a good idea.
No,
So
no,
I'm very
no, no, no.
careful personally. Yeah, I know we both are very careful on what we claim to know and what we do know. And we're like, I don't know it. Go ask her.
Yeah.
Not even
Yeah.
going to go there. So I think it was important that I wanted to let people know that first thing I said is like, I don't work in primary care. Don't ask me primary care questions. But I'm giving you the Medicare guidelines and I'm focusing on our specialty groups, what they need to know. So it was a nice take on it and I really enjoyed it.
Yeah.
And a couple of things I want to talk about today, and actually our first segment. Welcome back to our What Would You Do segment. And we're going to talk today about something that was mentioned during that May Mania session. And it's a question I've gotten before, but I knew it was something we had to talk about today for our compliance tip because we need to understand some of the conversations that are happening behind the scenes. And
Mm-hmm.
people don't know how to deal with these situations. So here's the question, guys. Get your ears out, get your compliance policies out. Let's see what you think about this. What would you do if a physician asked you to write off a copay or not bill a charge entirely? And we're talking about for a single patient, they want to help. Maybe they know him. Maybe there's a special relationship, right? We got stuff written down on that. But think about it, guys. We have guidance anywhere? Is this written down somewhere that this is a violation? What do you think, Maya? Do we have information?
We do. We do have information, and there has to be documentation as to why you're doing it. They have to prove that there is a financial hardship. And typically, if there is a need for help, they really should be a protocol or even a policy that officers should use when there is something that is going to help a patient because of their ability to pay. But there has to be proven their inability to pay by these policies. And so if that happens, you need to ask the doctor, why are we helping this patient? There needs to be documentation that they have a financial hardship. Once it's documented that there's a financial hardship, then you wouldn't be technically helping the patient. You are going by a protocol that is set by OIG so that you are doing the right thing, the right time, and the right way.
Exactly. And, there are also situations that I've had physicians ask me, well, my buddy over here, I never charge him for anything. And so there's an internal, like maybe a assumed kind of concept between physicians that they're just going to write each other's charges off. And there's that concept. But really what we're thinking about is, do you treat every patient the same? Because we can't pick and choose who we do favors for. We have to have a
Right.
policy. But there's also the concept of that second part, right? Not billing a charge entirely. I've had situations where physicians say, well, the RVU or the RVUs are higher for this procedure, but it's bundled. Can we just bill this one because it pays more? So I was like, I know why you're thinking that, and I know why you want to do that. You're trying to make the most money you can, which you're a business owner, you want to make money to take care of your patients, to keep your doors open. I understand that, but we have to do it compliantly, and you have to tell the truth. We talked last time, our last What Would You Do, about what the fraud, waste, and abuse laws say. If you're misrepresenting what happened, it's fraud. It's any misrepresentation that is not telling the truth. It's against the law. So when we're dealing with Medicare patients, and we're dealing with the federal payers, and then the OIG, the Office of Inspector General, for those of you who don't know that acronym, that of course monitors the activities of these programs, then you are putting yourself at huge risk. Fines upon fines upon fines, as we talked about last time, per violation. And I'm not going to lie, I'm pretty sure I can tell you from the conversations I've had with certain facilities, the types of questions I'm getting, I guarantee you there's probably more than one violation happening if they're asking certain questions.
Yeah. And I also think that it's all about education, right? And the education that's associated with those types of situations. And it really is contingent upon who's going to be ahead of your revenue cycle, especially in a hospital setting. They got to be cognizant of not just making the money and managing the money, but how to keep the money. And how many times have you seen where the revenue cycle gets a letter where it's a rack, it's 45 days, you get the letter, it's the 44th day, and you're like, why didn't anyone tell us that this is an issue? So one, when you're a part of that revenue cycle, I really do believe that there should be, okay, this is what you do for revenue cycle, but this is what's compliance. And you need to know the difference between the two and when to act upon it. I don't really think that those worlds are really intermingled as much as they should be. I talked about that revenue cycle and compliance risks between the cracks. There's so many things that we are unaware of when it comes to revenue cycle and ethically and moral standards, and that gray interchanging circle area that really needs to have constant communication that just doesn't happen. And we have to be assured that is something that is happening, so that the OIG isn't knocking on your door, or you're getting a letter, or somebody is blowing the whistle and you're like, well, why was somebody telling me? And you're like, you haven't billed copays in 10 years. Hello.
You've got $3 million in credits. Oh my gosh. That's a little extreme, but you know what I mean? Like, you're not refunding your patients, you're holding on to that money. It's not yours. That's not okay.
And not to
So
mention contractual obligations from commercial payers. That's
yeah,
still
I
just as
mean,
bad. Just because it's not a federal payer or a state payer doesn't mean that you get away with it. It just means
and
that it's a different payer.
your state has regulations on those things anyway. Like they regulate those types of things, and people just don't know all the laws because they don't have somebody helping them. So, I mean, I know smaller practices maybe can't afford to have, all these different departments that cover these things, but it is in all actuality more reasonable and actually more economical to actually have like someone like you and I on
Yeah,
retainer. Like, can you
yeah,
imagine, like, having someone on staff full time doing that is expensive. So I always tell these small practices, you actually will save money,
yeah,
tons of money, by having a
yeah,
consultant like us
yeah.
on retainer that you can just go to them, for
Absolutely.
your help. Like,
Abs-
you'd have a lawyer on retainer, I'm sure, if you're a healthcare practice, you have a question or a contract you have to get done. Usually that's just something that's common for lawyers, right? So you do that. Why not protect your practice in other ways, because you need that of course backup and support. um
you know,
it-
our age, it's an ounce of prevention is worth a pound of cure. So why not prevent the problem before it becomes a bigger problem? You know, and honestly, because the doctors are really focused on business, they're not focused on risks. So you have this one area that the doctor wants to be successful and have all these patients, but they're not considering the amount of risk when they sign a contract, when they accept Medicare payment. There's conditions of participation. There's a condition of participation for a reason. Hello.
mhm.
So, you know, and if there's no one there to explain it to them like us, then there's more likelihood of issues down the road.
There is. And we talked a lot recently, right, about the relationship that patients have with their physician. They find a physician they like, and they do expect that that physician hopefully is going to be ethical and also understand those things as well. But they talk to their physicians, right? They're buddy with them, like, oh, I know that physician. He's my best friend, and he'll take care of me. So one of the things that happens, right, in these situations is they go to the physician and say, I can't afford this, or like, I'm having this issue, can't, and the physician's like, oh, we'll take care of it for you. And no one ever involves the front office, the ones that have to deal with this. And then like, oh, the doctor said I don't have to pay today. And
What
how do you handle those conversations? It happens all the time.
it
And I'm
does,
just like, it happens, it happened to me once. And I'm like, no, they're not allowed to tell you that. So here's the thing. They look at the physicians, and if it's a private practice, like, they're the boss. They own the practice. They're the boss, right? But unless you're paying them cash and you have no insurance, they are no longer the boss. They no longer get to tell you what's right or wrong if you want to use your
right,
insurance. Because
right.
guess who's the boss?
Insurance
Your
company and the
payer, right?
contract. Yep, that's right. That's right. And I don't think, like I was talking about conditions of participation. Condition of participation for Medicare and the contractual obligations for the insurance companies, that is what gauges their obligation to pay you. If you fail to meet those obligations that are set aside for when you sign that contract, or you fail to understand what your obligation is, like setting those utilization review, the utilization management, where you have to send those codes or those and I'm so old school, but when you have the utilization of when, the usage and proving that these patients were actually seen by means of your capitation, if you're a managed care policy, all of that stuff comes into play. All of that stuff is huge. And if you fail as a physician to meet those obligations, they have a right to term their contract. You have no rights at all. And I'm seeing more frequently providers feel that they're being done unjustly because they don't understand what their obligation is. And I think part of it is education, but also part of it is like being a patient. When you understand your insurance, as an insurance, you need to understand your contract. And if you don't understand your contract, then you have an issue because you're failing to understand what your obligation is, even though they're meeting their obligation by paying you.
Exactly. So That is what we have to deal with, and we have to speak up and say, I'm sorry you were told that, but unfortunately the physician doesn't have the ability to make those calls. If you want to bill your insurance, we have to follow the regulations that they've set out, and we can't do that based on the laws that are governed by the federal government. Like, throw it
Absolutely.
back on the federal government. Do you want to defraud the federal government, ma'am? Do you want to? I don't want to. You know, you got to make them aware of how serious it is, because a
Yeah.
lot of patients don't even know how far this goes. They
Yeah.
don't.
It's like onions. There's many, many, many layers to how to accept payment the right way and to make payment the right way. I always think about Shrek. Shrek is the insurance company and the patient is Donkey. So, yeah.
Oh my, I love it. I love that mental picture I have in my head right now. I love it. I love it so much. Now I'm gonna have to go watch Shrek and be like,
Right.
I love it so much. Well, you and we're good at communicating, I think. I think we got good communication skills.
Absolutely.
Have you ever run across someone who does not communicate well and you just have to like, can you say that again? Can you reword it?
Yeah.
And
Yeah.
yeah.
But I also think, and I think the role as a coder, right, is for us to understand the language. That's what we went to school
Mhm.
for. That's what we're trained for. That's what we're understanding. We have to understand the rules and regulations that are associated with keeping payment. And when a patient says, well, I don't know. Okay, well, that's when those questions should come into play. Okay, is
Mhm.
there, do you need to? And so you have to create those types of environments and know when those bulbs should be coming up, where that conversation should be taking place. And if by chance you are not able to make that conversation, then you need to defer to somebody who does and know and stay in your lane. If you don't know it,
Absolutely.
don't make up something so the patient could feel better by what you said. You're not doing anybody. Well, I talked to this person and they said, you said that? Well, I didn't know it. Oh, no, 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 no. I've seen that happen too.
Mhm. All
And
the time.
and sometimes you you have to be really careful, especially when it's us and we're the patient, and you like, okay. And you try not to correct them, but you kind of say, well, okay, well, is your manager around? Can we talk to someone? Especially when it's your loved ones, right? You try
Mhm.
to, I won't even go there, but we talked about that last season, or was it the season before last? When
I
your
don't
loved
know.
ones have, when your loved ones are involved, and you're trying your best not to say what you do daily for a living,
Mhm.
and
Yeah.
get it correct and corrected before you put on that hat and show that badge. Listen, I'm a certified coder. Oh, and then they're fumbling over themselves. That's not something
Oh,
that
yeah,
should
I
be
love
happening.
it. I do love doing that at medical offices, and, like, I do love doing that. It's fun.
Stop it.
Um, no, we're mean, right? No. So, in those situations, I'm not picking on the front office. I'm here to educate the front office if that's your role, because a lot of times, and it's not your fault, you go out there looking for a job and the medical office says, this is the role, we're going to train you. If you have good customer service skills, that's a lot of times what they're looking for. But there's more to that job, obviously, than having customer service skills, as we know. You have to know technical jargon, right? You have to know the technical terms for the payers, what to ask the patient for, and your specialty
Mhm.
has a lot to do with that. So, as an example, I worked in plastics and I've also worked in ophthalmology, and sometimes both of those meet. So, in ophthalmology, for instance, it's customary for you to know you have to ask for their vision card and their
Yes.
medical card, because
Yes.
you may or may not know what's going to happen and where you're going to have to bill things a certain way.
Right. And
And
people
then,
aren't aware that those
yeah.
are two different benefits, right? I mean, we won't even talk about behavioral health because, but all of those things, especially vision and dental, are different benefits through your carrier. And if you're not aware that those are different benefits, and you should have, on occasion, and most of the time when you have 3 different visions, you should have 3 different cards. Seriously. Your dental card, your vision card, and your medical card. And contingent upon the type of service you're getting, you need to know where your benefits fall. Again, that's the onus, our friend Kim says, the onus that we have to take as patients, as consumers. The more knowledgeable you are, the more helpful you are to the office, because then they are aware what you are aware of, and then they can apply those services accordingly.
100%. And, I think about all the things that we have to do when we are in the front office, because I'm speaking from experience, because that was my first job in healthcare, was at the front desk. It's a high stress position. It is so stressful. Even for one physician practice, it can be a lot for a person to take on. And then you start adding multiple physicians to the practice, and it becomes more overwhelming. So we can see why nowadays we need technology to help us be more efficient. But we have miscommunications. We have things we have to take, information we're taking from the patients that's not always about their insurance. Have you ever been up there and a patient just starts telling you all this stuff they're going to tell the doctor, and you're like, wait a minute, let's hold please. That is information maybe you should save for the physician. Unfortunately, I'm not trained, but I can pass that information along. If you want to write all that down in your paperwork, then the physician can see what your concerns are, and assure them, when you call to make your appointment, we did submit that information in your chart, so the physician knows what your intent for your visit is today. But please make sure to keep all your questions for your physician and for your nurse to talk those things over with. So it's, again, like, it's a matter of, making the patient aware of the workflow in a nice way. Like, you're not saying, I don't want to listen to you, I don't want to talk to you right now, but you're expressing you're empathetic for them. You have empathy for what they're going through, and they're just so excited, and they have so much to say, and they just want to talk to somebody about it. And so some patients are like that. They're just chatty. So they're just going to tell you their life and what's going on with them. So if we don't pass that information along in some way, or get the right information, it confuses the patient and the physician when they get together. So there's also conversations you have to have with your teams about making sure you don't hold pieces of information to yourself. So there's training that needs to be done, right? Training. Okay. So so this physician will usually, this is what my experience was. When I worked to the office, I was new. And so they said, for this physician, we schedule this way. And for this physician, we schedule this way. And if they're a new patient, we have these slots. If they're an established patient, we have these slots. And so you had a lot to keep track of. But once the schedule was built the right way, when we started getting EMRs and all of that integrated, and we had all that cool stuff,
we'll go there.
It became a little easier, but then you have the added caveat of not setting it up right. So, I mean, that is working against you. But when you know your role and you know how you're supposed to do your job, which physician requires certain things, then they're going to get the right information. They're not going to get random patients being scheduled. So someone told me this last weekend an experience, and it really was a great experience that I'm going to write down about communication gaps, because what happened is nobody paid attention that the patient was scheduled for the wrong physician, the wrong type of physician. She had one issue, but they scheduled for another physician, and that was a completely different issue. They didn't check the notes to say, okay, like, they have this kind of pain in this body region, so they're going to have to see this physician versus this. So they go all the way through appointment. Nobody is making any connections. I'm surprised the physician didn't catch on when she starts talking about her symptoms. Like, I don't deal with that part of the body. It was an orthopedic practice where they have things separated, right? So they're like, why are you seeing me? That should have stopped the visit right there. But guess what? It didn't. They went through the whole process. They billed it out to insurance, and the patient was upset because she goes, well, then they had to reschedule her for the right physician. She goes, I don't have to pay for both visits because that was your error. You should not have done that.
Just avoided that claim. That's right.
in actuality, they did fix it and they did it the right way, but that could have been avoided altogether, and all that
Yeah.
confusion, that headache for the patient having to come back, if you just paid attention and communicated correctly to the right physician. And if that communication gap wasn't a problem, and you actually communicated well, that could have saved a lot. So that's a really good example of a communication gap that
Right.
is very maybe common. I don't know. I've never seen it happen in my world, but I've heard stories about this happening
Right.
in many different ways. Miscommunications that lead to duplicate visits. So
Right.
it can
Yeah.
happen.
Yeah. And I was also going to say that, when you're dealing with communication, it also could lead to another area that has now been prevalent in the last 2 years, which is SDOH. I need a virtual visit. I need some help because I am in between homes. I just had a divorce. I just did this. I just did that. So, that type of communication that is, maybe given to the front desk, and it's making a difference, putting those types of notes in the system. So when they go to the back and the MA sees the note or what have you, it can make the difference on how and what is being done to how to address those types of issues. And that could generate more revenue for the office when they come across those situations, especially if they're in that type of population or that type of community where it's more common than not.
Exactly. And so we know this season is about the connected leader. And remember, we talked about in our first episode that a leader is not a manager, it is anyone in the organization who has leadership skills. So the next thing I want to talk about is how we communicate with necessary written communication. So that is our documentation, right? And it could be anything we write down, either digitally or with pen and paper, which is still common in many situations. We still have to write things down.
Yeah.
But I was thinking as I was preparing for today, and just in general thoughts I have on communication lately, is back in the day, I grew up in a time where we learned how to handwrite. And in school, we had actual classes on how to do that. And then we even had speech class. I took speech class. I don't know.
I
I
did
meant
too.
to look it up. I meant to look up in our local area to see if they still offer those kind of classes, because I was
They
wondering
don't.
if they still offer them.
Nope.
I don't have kids, so I don't know what's going on in the school land. So
Right.
I just wondered if they even have those anymore. But that's a necessary skill, right? To communicate, right? So you learn written communication, you learn verbal communication, different
Yeah.
types, right?
Yeah.
So that I feel like is a lost art, and we know why, because of technology. Social
Yeah.
media, texting. You see these kids today, like they just type shorthand, and like they can't do complete sentences anymore.
Right. I
It's
think
just like,
tangibility in the office, or tangibility period, and is being replaced with AI
mhm,
and virtual conversations. And there's one thing to have a podcast and to talk like you and I are talking, is to get the message to the masses. But for someone that is like my kids' age, their idea of having fun with someone is literally talking to them on the phone or meeting them through whatever Tinder, whatever. I don't even know what the websites are, but I mean, it really scares me, because I was like, how do you even know what color they like? How do you know what foods they like? How do you know what they are when they sit down in front of you? Their body actions. How do you tell that? You can't. So when you see all of this automation and virtuosity, if you will, that's related to relationships and conversations, it really gets you to wonder what they really are thinking up here, and how that process is taken into play, because there's a lot of depression in younger children because of what they see versus what they're experiencing in person. So there's that, you have that piece. So you know um automation and virtuosity and AI and all that stuff, that is the to me, that's the bad side of taking away the benefit of tangibility. That's just my take on it.
100%. And um because this is an issue and it's been an issue for many years, I'm seeing a trend when I'm going into offices that I've been going into the last year to help them with workflow and compliance. And the one office I went into, what I realized was they have some younger people in the front office. And the younger and younger we see the ones going in there, they're coming from a generation that is different than ours, right? And so they're coming from a generation where that is not taught to them. And they still have to communicate to patients that are walking in the door. And if they're on their phone with their head down, which I've seen still, they're doing that, and no one's talking about it, and they keep doing it, and like, oh hi, like they're not with it. They don't even know what's going on, which patient's coming in next. They walk in the door, and they're like, oh hi, what's your name? And like when I was doing it, I mean, I didn't have a cell phone when I first started, obviously, but I always kept it in the drawer because we were told to do that. We could use our phones at lunch and on a break or whatever, but we were supposed to stay focused. And so I anticipated that. I knew that at 10 o'clock, Mrs. Jones is coming in. And in 30 more minutes, I'm going to have some more check-ins, Mrs. Avalon or what, I'm just making up names. But, it's like they're coming in and I'm anticipating that. I know I already checked Medicaid. I checked their Medicare replacement plans. I made sure that I knew that copays were documented, that I'm going to collect this. There's so many things we do, but when we prepare ahead of time and we're not distracted, we can get a lot done.
Yeah.
And so when we're hiring these people, and this is why I'm going to give this is my special announcement. I'm going to be doing some advocacy, the rest of this year and next year on communication training.
Yeah.
And so we have some great things coming down the pike this year from Healthcare Inspired and our partners in other consultant agencies, where we're going to be working together to create relationship and communication training for your medical offices, because you are going to have to hire new generations as time goes on that are going to be more and more removed from communication skills because of the nature of society.
Right. I totally agree. That's so undervalued. And then when you're dealing with a large corporation, there's called on the onboarding process, and the onboarding teaches you fundamentals of how to navigate, but it doesn't teach you the fundamentals of communicating with the patient. So I really do admire the fact that this is something that has been recognized. The concern that the younger generations don't even know what to ask, when to ask, because they're expecting the system to be correct all the time, when the system is based upon what somebody builds and not necessarily understands. So that is a huge and almost, and I even want to go to say, Jen, that that's probably why a lot of businesses are not successful, because they are failing to realize all of the things that they're supposed to do and not doing. And contracts, conditions of participation, understanding all of that, and how your office comes into play with all of that is going to be key for the survival of these smaller practices.
100%. And, I have a surprise for you, Maya, and you probably didn't know we were going to do this, but we're going to do some role playing. And so no pressure. You don't have to do anything fancy. You just have to be a patient. Okay. And we're going to show our audience and those of you listening to the podcast later on in audio, you're going to not be able to see this, or you can always go to our main YouTube channel, Healthcare Inspired LLC, and you can watch the visual of this. Please check us out on YouTube. It's a great way to experience these sessions and actually see our faces. But if you're listening, you're going to listen to this conversation about how you properly ask questions to your patient when they come in the door. So Maya's going to come into the office and she's going to tell me some things. And so I'm going to start out and say, good morning, Miss Turner. How are you today? How can I help you?
Hi, I'm here to see Dr. Smith, but for some reason, my daughter got in the way and I was late. But but I'm here now, and I'm really excited to see Dr. Smith, because I got a whole lot going on, and I need my prescriptions filled.
Well, I'm so happy that you're here, and I know that you're anxious to see the physician. I know that you did say you were a few minutes late. Let me run back there real quick and just make sure that we can still honor your appointment today so that we can get you what you need.
Okay. I'm really okay. Please, I got to see him because I need my prescriptions filled, and it's been over a year, and I couldn't get it over the phone because they told me I had to come in. I please go back there and see him because I really need to see him today.
I completely understand, and I empathize with you. And so I'm going to go back there and see what I can do and see who may have told you that so that we can iron that out. But again, I'm here to help, and we'll do our
Okay.
best to get you your answer today.
Okay. I forget what the girl's name, but she thought it was okay for me to come. I called in, but she thought it was okay for me to come. So that's why I'm here.
Well, wonderful. I will check that out for you. Just hold on 1 minute. If you want to have a seat, I'll be with you momentarily.
Okay, I'll sit down.
Done, right? I mean, that's a basic, one-on-one that could occur, right? And I'm not saying every person that sits in that desk is going to have the same personality as me and do things exactly the way I did it. And that's okay. You don't have to say what I said. I was just flowing and I was just trying to be, Miss Patient Whisperer here.
Oh,
But you
good.
can do it your own way, right? You can say it your own way as long as you're doing your best to make the patient feel comfortable and ease their burden, because guess what? They're the customer. And I'm not saying the customer's always right, which is a phrase that we hear sometimes, right? The customer's always right. They're not always right.
No,
But
they're
what
not.
is right and decent is to treat them like a human being.
Exactly. I remember when CJ Wolf was on our show, and he said communication. At the end of the day, everybody is, it's people that you're speaking with. People are people, and they want to be understood. If they're not understood, or they don't feel like you are understanding what you're trying to say, they feel indifferent, and they almost get offended because you're not trying to understand, or they're this blank. And if you're robotic, it just doesn't work out well. And the likelihood of somebody coming back because there is no empathy, because I think empathy is also part of customer service. If you don't understand a situation and the need for that patient to see or to be, their situation to be addressed, I think that is, a big problem.
Exactly. And, I'm not going to lie, I've had experiences going into our next relationship, which is our physician patient relationship that we're going to talk about. I've
Yeah,
seen in my own life in recent times where this has been a problem as a patient. And I know that a physician has bad days. They have a lot of stress. And even for those of us that work in the business side, we have maybe bad days. We all have bad days. We're never going to have a perfect day
absolutely.
all the time. But sometimes we bring it with us to work and we can't compartmentalize, as they say, and separate our life, our home life from our work life. We just can't. It's just with us. And that's understandable. But when you think about the role physicians play and those of us at the front office, the ones that the patients rely on to kind of set the tone and make them feel welcome in your
Right.
organization. They want to feel
Absolutely.
welcome. They want to feel cared for. And so in some way, I'm not saying I do it perfectly when you're stressed, find a way to not make it about yourself. Find a way to make it about them. You may still have a bad day, but can you in some way not show it on your face if you could? For that moment in time, those 30 seconds you're talking to them, let it be about them and not you. Don't look
Right.
internal, look external and focus on the person in front of you.
That
Now, it's not
that
always easy.
Yeah, yeah, yeah. And I think that's what customer service is about, right? You have to have a bottom line to service the patient. Patient access is a term, but customer service is the role. So when you understand that you are of service to those people, it can't be about you because you're supposed to service the patient. It's about patient's access to the physician. You are the key to show them, that this is how we do at this office. This is how we treat our patients at Dr. Smith's office. We love our patients, but what are you here for? You here again? What you want? What? So no. The bottom line is service. And if you understand what that is and understand what your role is to service the customer, then you probably are going to be better fitted for the front desk because you understand what it means to service the patient.
Exactly. Now let's talk about a scenario that happened to me personally. I will share this experience. I think I've shared it before, but it really fits in line with what that we're talking about today. And I want you to tell me, Maya, after I'm done with this story, where the gaps happened and where they could have been filled, maybe to prevent the feelings I had and the way the physician talked to me, where that could have been alleviated along the way. So
Okay.
I call the office to make my appointment. I had previously been in the ER for something that was kind of scary to me. They told me I was okay, but they said, go ahead and go to your physician and have it checked out. But I also was experiencing some other symptoms that, because of my age, I was thinking, okay, let me just talk to the doctor to see if these are things I should be worried about for my future. Is this an age related thing? Am I going to be experiencing more of these? What do you have to say about my symptoms? So I have this scary thing that happened. I just want to make sure that I'm not worried about that. And then I also want to talk about these other symptoms I've been having. And they're all related to the same body system, right? So it's not like I'm talking about ortho going to neurology. Like it was a completely separate thing. So I told that to the front desk. Now I don't know what they put in their computer. I don't know what they put down. I know they gave me a time to show up and they told me, we'll see you at this time. Make sure to bring your copay, which I was like, good job, girl. Tell me to do that. And so I get there and I go in and I've seen this nurse practitioner before. And I didn't it's been a while. I didn't remember the last experience I had. It'd been a while. Before COVID, I didn't do doctors very much during COVID. I was like, I'm good. So I just didn't. But I go back and I start, going in through it, and she's got this stone cold look on her face and not a warming look on her face, where you feel like you can talk to them. And so I'm just doing my business, just saying, okay, this is the chain of events that brought me here, so to speak. And you can probably get the records, on the portal, from the ER and from the urgent care that I went to. And having these additional symptoms that I just wanted to discuss. And she goes, oh, whoa, whoa, whoa. We have to only take care of this in so many words is what she said. I mean, she may have said it differently, but we can only handle this today. I don't have time for the other things, but we can schedule another appointment for that.
That was a nurse practitioner?
Yeah. And so there may have been several factors that led up to that, but I was walking back in my mind because I know how it is to work in an office. Like, is there a protocol they have on certain things that wasn't explained to me as a patient? So like for you, Maya, if you were walking into that situation, what would you expect from each member of the office from the first encounter to seeing the doctor? Like, what would you normally expect?
Okay. The first thing is what type of appointment type was put in the system, right? It should have been an ER follow-up. The ER follow-up should have some sort of protocol or some sort of precedence because you have come from an emergent situation, right? That's the front desk. That's the first thing from when you call, when you put it in the system, the ER follow-up should be patient was seen in the ER was told to follow up with the physician. So to me, that would be the first thing. The second thing is once you were placed, and an appointment was placed, there should have been some documentation to show why you are coming from the ER, not just because first you have the appointment type and then the additional information to support, right? And so after that, once you are taken to the back, the MA should say, okay, why are you here today? And then that should have been, I had this happen. I had that happen. I had this happen. I'm also having additional symptoms. I need to talk to someone. Okay, that should have been put in the system. So by the time you got to the NP should have said, read the record, read why you were there. You were in the ED. You saw blah, 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 blah. You have some additional concerns. Because of time constraints, maybe I'm not able to get to everything. Maybe I could talk to the doctor to see what we can do. But she should have been in the collaborative relationship. She should have been able to talk to that doctor to see if there was something that she could do to help ease your concerns. But the fact that she stopped you dead in your tracks, that lets me know, A, there's a culture that needs to be changed, and B, there needs to be education in regards to how that nurse practitioner addressed your problem. Because it could be that there was a bedside manner, it could have been that it was a bad day. But at the end of the day, if you're a patient and you're presenting with these problems, and then that problem becomes an issue, or there is a bigger issue because of that, and it's documented that you addressed it, that's a liability. That's a compliance issue. That's a risk, because you're saying it and she didn't do anything about it. But even though the record is consistent that it was an ER follow-up, you have these symptoms, you have this, you have that. So there's no streamline. It should be a dotted line from the time that you called all the way to the time that you see the physician. Now, my question is, what does the documentation state that you spoke of for the nature of the presenting problem and the illness or the issues that you were there for follow-up? And if in those type of situations, it should be very clear what was addressed, how you presented, and the level of service. Though she better not have billed a 5.
No, she didn't. But I will tell you, it was bare bones. It was not what the full encounter happened. And so previous to that, this is another, and this is, I'm telling you this now because it's going to give you insight into the flow, right? So when I went to urgent care, another nurse practitioner, not I'm picking on nurse practitioners, they're great. There are very competent ones out there. But again, I had been sick from my trip to California, and I got tested for COVID, all that kind of stuff. But I also had been in the ER 2 days ago, and the same thing happened again. So I go back to urgent care instead of going to the ER, just let them know, because they told me I was fine. But I was just really concerned. So I went to urgent care. They discussed, all she wrote down was the COVID stuff. That's the only thing that she wrote down. And I'm like, and I'm getting my note because I'm in the app, right? I get it. And I'm just like, now twice, 2 nurse practitioners in the last month of my life have not given the full story in my notes. And so there's a lot that we need to fix in cultures and in organizations, but internally as well.
Yeah.
What do we want our patients to see? Yes. But what is the truth of what happened? Because it's not just about you. Like I always say, it's not about me. If I'm a physician, I know I'm not the only physician that's going to see that chart. And it's not about being a reimbursement to what I can get paid for. It's about what happened to my patient and what they need. And they can't get what they need if I don't tell the story, because the next physician's not going to know anything about this problem I had. What if it happens again? They have no history on it.
None. And to me, that's not only a compliance issue, that's a risk issue, because
Yes.
I mean, and just that situation, that is everything that's related to a lawsuit had that become something more adverse, or there's a reaction in regards to it. Because if there's documentation to show that you called, it was a post-ED visit, and the note was bare bones. They didn't address all of the issues. They didn't give you anything that you needed to resolve those issues from the ED visit. And it was evident that the issues from the ED were, the nature of the concern, especially if they pulled up the ED records. So, in my eyes, I see that as risk red flags all over the place. And the fact that there was not enough follow-up, or there was not enough that was addressed, tells me that A, there's a culture issue, and B, there's a reason for this could become more of a risk record. And someone like me, and in my old job, that I would have looked at all of that prior to that, and I would have advised that this is a risk, and this patient and or this nurse practitioners should be educated and in a nice way.
Exactly.
Yeah.
And so we've had these discussions, today. We've talked about just in general how we communicate. We talked about the 2 main things in the clinic that really, from point A to point B, where our front office staff, their first line of defense, and then with the physicians, how they interact. So these are just 2 areas of communication that we talked about today. But I've got more to share with you guys, and I wanted to announce officially right here on the podcast that my book is done. And I'm very excited that it's in production and it's in editing and all that fun stuff. So we're going to be releasing more information over the next few months. I have a lot of other contributors that are really contributing their stories to the book. It's on communication. I will give you that much. It's about how we communicate in healthcare. And it's going to be my life talking about my experiences in the world of communication, how I learned to be good at communicating, how to communicate well with my family and others, the training I received in my life. And then also talking about, again, we have to talk about the bad stuff. I will be talking about some bad examples of communication, but we're going to have some great interactive tools for you in the book that are going to help you do better with your communication. So it's a hybrid, memoir / how-to book. So you can actually feel like you can get better at communication. And then, as I mentioned, there'll be a lot of advocacy over the next year with medical practices, helping them to see the need to provide cultural and, technical communication training to their staff. So
Yeah.
I hope it's well received. I hope y'all enjoy it, and we'll give you more details as time goes on. So again, thank you everyone for listening in today to the Healthcare Inspired podcast. And I want to thank our co-host, Maya Turner. Maya, what do you want to say to our audience to close out today's show?
I think that there is a lot to be said about communication. Communication is the effective way to express a thought or a concern, and both parties walk away understanding that. And in the world of healthcare, that can be implied and not communicated. And if there is a lot of implied thoughts rather than communicated thoughts, you're going to get a lot of issues. So if it hasn't become a culture for your staff and the physician to talk about the workflow, about the day-to-day, about policies, then you need to start thinking about that and think about how many situations that could have been avoided should you had a policy.
Exactly. So we're going to have some great episodes coming up. And next week we have a special guest on the show, and it's going to be a surprise. So I look forward to sharing that with you, and we'll let you guys know sometime next week who our special guest is. But stay tuned for our next episode. And thank you again for being a loyal listener. Please rate, subscribe, and of course, share the show, Healthcare Inspired, Season 3, The Connected Leader. Until next time.